So now we move on to our next talk, and that is by Dr. SWAPNA Nair, and she will be talking about how does intracorneal ring segment help, when to do, type of ICRS, and in which cases.
Thank you, Dr. Rajesh, for having me here. ICRS is another form of treatment for keratoconic eyes, where you try to provide some amount of visual rehabilitation also. So, as we know that myopic LASIK, it removes central corneal tissue, and by the same mechanism, adding tissue to the periphery, as is done using ICRS, also corrects myopia to some extent. Now, besides correction of myopia, there is also some space creation between the corneal lamellae in the periphery, which leads to a shortening of the central arc length of the cornea. And this causes a redistribution of the stress. Now, this was studied by El Husseini in 2013. And they found out that this redistribution of stress, it changes the disease course to some extent. So these are the two mechanisms, and these are two basic facts on which application of ICRS depends. So ICRS is inserted in the posterior stroma, being less compact than the anterior. And now there are two factors here: the diameter of the ring and the thickness of the ring. So diameter of the ring means the circle from which that ring arc is made. So the shorter the diameter, the higher amount of myopia that is treated. So it's and secondly, the more of dioptric correction is treated, provided you put a thicker ring. So the rings I usually use are the Intacs, and that varies in thickness from 0.21 millimeters to 450 microns. So depending on what amount of correction you need, you can increase the thickness or reduce the diameter. Now, basically, when there is loss of lines due to corneal change, or you have a high dioptric corneal value, with a central clear cornea and a minimal pachymetry of 450 microns at the point where you want to insert the ring segments, are the indications for the condition for this procedure. And these are the various conditions in which you can use. So basically, for ectasia without central scarring and with a minimal residual corneal thickness. Now, you won't do the procedure in corneal scars or dystrophies, or when you have recurrent corneal erosions in pregnancy, any sort of autoimmune diseases, and drugs that affect the cornea. Also, you have to be careful when you are doing this in patients with large pupils and with a lot of eye rubbing, that is likely to cause a rapid progression of the basic disease itself, and with low endothelial cell counts, because we are dealing with the posterior cornea over here. So now there are different types of intracorneal ring segments, namely Intacs, the Ferrara rings, Gero rings, Mayo ring. So Intacs have an arc of 150 degrees. They're hexagonal in cross section. The later ones also are oval in cross section. You have two types: the standard ones that are used for smaller dioptric powers, and the steep K ones, which are used for higher dioptric powers in the range of around 57 diopters of corneal steepening or more. So there you have a shorter diameter than the standard ones, because we saw that a smaller diameter corrects more of myopia and flattens the cornea more. So the Ferrara rings are again PMMA ones, but with a triangular cross section. And they basically have a height of the triangle and a base of the triangle, the base being 600 to 800 microns, and the height is on which the correction depends. The Kera rings are similar to the Ferrara rings, though they have two extra segments. The Mayo ring is a completely circular, a donut-shaped ring that can be inserted in a corneal pocket, and it has an upper convex and a lower flat surface. Now, coming to the insertion of Ferrara rings, this is a manual dissection of the cornea for insertion of the intracorneal ring segments. So you can see that a vertical cut is made to define the pockets through which the ring has to pass. And the pockets are taken completely circular, and then you can insert either one or two rings of the same dimensions or different dimensions, depending on how symmetrical the cornea is. So if you have a decentered cone or an asymmetrical astigmatism, then you may suffice with insertion of one ring. But if you have a very symmetrical central cone, you may need two rings of nearly the same dimensions to flatten that. So here you see that once the pocket has been made, a ring is being inserted. So here you have a pre-existing dissected pocket into which the ring is inserted. Now, here is the pocket for the myo ring. So either using a dissector or the femtosecond LASIK, you can create a pocket of around 9 millimeters at 300 microns into the cornea. And then the myo ring is placed centered on the pupil. So this being having a convex surface on top and a flat surface at the bottom, again stretches the cornea centrally, decreasing the arc length and therefore correcting the amount of myopia. Intacts, either you marker there. So I use a Sinski hook or the end tip of a chopper to just put the mark over there. Is achieved. The pocket for the intacts are made very fast because the laser fires simultaneously in a ring manner, and then it creates a central cut. Now this vertical cut happens along the portion where the positive astigmatism happens. So this is the axis of positive astigmatism where you start inserting the rings or the point of the vertical cut. So then now these pockets are latent pockets that are made by the femtosecond LASIK. So you start dissecting them first just to create two entry points. Then you start inserting the rings, and it is using these rings that the rest of the pocket is dissected. So you don't need a separate dissection for that. And depending on, like I said, the centration of the cone and steepness of the cone, you can insert symmetrical segments or asymmetrical segments. Now, once they're inserted, you have to make sure that the end of the segment is about 1 millimeter inside the pocket so that it doesn't extrude spontaneously. Another caution that is used to make sure that there is no spontaneous extrusion is insertion of a suture at the vertical cut that was made initially. So now this is there are various nomograms for to know what kind of ring has to be used and how you have to place and number of rings. So this is the latest one given by Addition Technology. There's one described by Dr. Rohit Shetty that was quite some time back in 2014. So that was a good way of using the rings. Now this is the one that has been provided by the company, and you can get it from the website. Now basic rules of planning I've already mentioned as I was showing the videos. So if you have a central myopic cone, try to put symmetric segments. If you have high astigmatic components, asymmetric segments, and a highly decentered oval cone, even a single inferior segment will do. And when you're dealing with highly asymmetric cornea, you can have a thin segment superiorly and a thicker segment inferiorly. Now, here another point to note is that the mid-peripheral pachy in the region of 6 millimeters from the center of the 3 millimeters from the center of the cornea is what is most important. So even if you have a low central pachy, if your mid-peripheral thickness is well built and quite good, then you can insert intacts. So you have to take an entire pachymetry map on, and not just the central thickness of the cornea. That it has beautiful topographic and visual results. There's fast rehabilitation, and you can reduce a lot of myopia and astigmatism using this. And now with the SK segments, you can go even further with higher diopter corrections. So this is how the post-operative picture looks, and you can see how the segments rest in the posterior part of the stroma. And you can always offer an additional treatment for this. So like, CXL or ICL. Now, you have to be aware of the complications, though I have done it for around 7 years now, and I haven't faced any personal ones, but superficial protrusion of the rings, especially in vigorous eye rubbers, extrusion of the rings or exposure of the rings can happen. On the other hand, if you've gone too deep or you have not assessed the mid-peripheral thickness properly, you can have an AC perforation. Then, of course, there are some deposits that may form around the rings that I have seen, though it is not very common, but some sort of white flakes that may form at the edge of the tunnel. Infectious keratitis in any pocket is a reality. Then there could be persistent corneal edema around the segments. And these are some of the factors, if going to the extreme end, may require explantation of the rings. These are the various studies, I know it's a busy slide, that have tested the efficacy and the safety of the segments. And these are the multiple combinations that can be used for along with these segments to provide correction of the basic condition as well as visual rehabilitation. Thank you very much.
Thank you, Dr. Swapna. Can you keep the questions at the end so that we'll now have Dr. Namrata Sharma with more details on the cross-linking aspects, types of riboflavin, and the current status of accelerated cross-linking. We can take a quick question if there is one while the setup is being done. We can go ahead.
One question from me, ma'am. What would you like to prefer for improvement in visual acuity? Is it using a intracorneal ring segments or using a PRK along with CXL?
Again, it depends on the amount of correction you need to improve the visual acuity. We know that in keratoconic cornea, it is not very easy or to take a decision on whether to do PRK, even if there is an added CXL to it. And when the dioptric correction is large, or even with PRK, we can just assume that we are, regularizing the cornea rather than treating the dioptric correction. So if you want to treat a large dioptric correction, I definitely would recommend ICRS. And if the correction is very small and you can do with just regularizing some amount of the cornea, then maybe